Hi everyone, and welcome to our module on vasculitis syndromes. The vasculitis syndromes are very rare, and it's unlikely you'll see many of them as a medical student or even as a practicing physician, and they can be very frustrating to study because they have a lot of overlapping signs and symptoms, and it's hard to keep them all straight. What I'm going to do in this module is try to give you the high-yield facts that I remember to recognize these syndromes and try to help you get them right in your head so you can recognize them in board exam questions. Vasculitis means there is inflammation of blood vessels, and the hallmark is to see leukocytes in blood vessel walls when you look at the vessels under the microscope. Because it's an inflammatory condition, there are often signs and symptoms of inflammation like fever and myalgias and arthralgias and fatigue. But then each condition also has organ and disease-specific symptoms, and most of these occur because the vessel lumen narrows or occludes from the inflammation as part of the syndrome. We classify the vasculitis syndromes based on the type of vessel involved. So the large vessel syndromes are temporal arteritis and Takayasu's arteritis. The medium vessel syndromes are polyarteritis nodosa, Kawasaki's disease, and Berger's disease. And the small vessel syndromes are Scherg-Strauss, Wegener's granulomatosis, microscopic polyangiitis, and Heinach-Schönlein purpura, and we'll go through each of these in this module today. Before we go any further, let me define a very important physical exam finding among patients with vasculitis, and that's palpable purpura. So purpura means red-purple skin lesions, and it's due to extravagation of blood into the skin. And a very important feature of purpura is that these lesions do not blanch when pressed. So if your skin turns red from increased blood flow and hyperemia, that will blanch when it's pressed. But if it's red from extravagation of blood, it will not blanch when pressed. And there's an example of someone pressing on the skin of a patient with purpura over here on the right. Another example of what it might look like over here up at the top. Non-palpable purpura are usually non-inflammatory, and these are called petechiae when they're small and ecchymoses when they're large. And you may know that one cause of petechiae is thrombocytopenia, so this is non-inflammatory loss of blood in the small vessels of the skin. Palpable purpura, on the other hand, only occurs in vasculitis. These lesions are raised so that when you drag your hand over them, you can feel them, and they are due to small vessel inflammation. They're sometimes called a leukocytoclastic vasculitis, and leukocytoclastic means that under the microscope you can see leukocytoclasis, which literally means destruction of the cytoplasm of white blood cells, and it means that there's infiltration of white cells and there's debris in the vasculature. So anytime you see a board question that describes palpable purpura, that is code language saying that the patient has a vasculitis, most likely one of the syndromes we're going to talk about in this module here. One other item I want to mention before we get into specific vasculitis syndromes is that many of these disorders are treated with either steroids or cyclophosphamide. You may know that cyclophosphamide can be used as a chemotherapy agent for cancer, but it also comes in an oral form, and it's a powerful immunosuppressant used in many of these conditions. And I talk about both steroids and cyclophosphamide and their mechanism of action and side effects in some of the immunology modules. So what I'm going to do now is go through the specific vasculitis syndromes, beginning with the large vessel vasculitides. And at the end of this module, I'm going to fill in the key features on the right side of this table that you should remember in order to recognize these conditions in board questions. So let's start with these two disorders right here, which are the large vessel vasculitides. So the two large vessel vasculitis syndromes are temporal arteritis and Takayasu's arteritis, and they both involve granulomatous inflammation, and they both involve narrowing of large arteries in the body. Temporal arteritis is also called giant cell arteritis, and this condition involves narrowing of the temporal artery system. So patients get symptoms in the face and head, so they can develop a headache, they can complain of jaw claudication, which is pain on chewing. And the feared complication of this condition is that if it's not treated, it can lead to blindness from occlusion of the ophthalmic artery. A classic lab finding of temporal arteritis is a high SED rate, and many of the symptoms of this condition are nonspecific, like headache. So doctors will often check a SED rate, and if it's normal, they won't worry about temporal arteritis, and if it's elevated, they will pursue the diagnosis. The way you clinch the diagnosis is by doing a biopsy of the temporal artery and finding granulomas. The treatment is with high-dose steroids, but importantly, you don't wait for biopsy, because if you wait, the patient can go blind. So if you suspect temporal arteritis, you begin steroids immediately and then schedule the biopsy down the road. The classic demographic is an elderly female. This is a picture of my grandmother here. She does not have temporal arteritis, but if she did, she would be the classic demographic. And I put her picture on the screen to help remind you of the classic demographic of this condition. So the classic case to know for your boards is an elderly female who has a headache and may complain of pain on chewing and has a high SED rate. And the question will often ask you about the granulomas in the temporal artery or the risk of blindness if the condition is left untreated. The other large vessel vasculitis syndrome is Takayasu's arteritis. In this condition, there's granulomatous thickening of the aortic arch and branches. Basically, granulomatous inflammation occurs, it thickens the arch and its branches, and that leads to abnormal blood flow. We'll talk about this in a minute. Up to 90% of cases occur in women, and the highest prevalence of Takayasu's arteritis is in Asia. The classic symptom of Takayasu's arteritis is to have weak pulses in one arm. It's sometimes called pulseless disease, and that's because it often involves narrowing of the proximal great vessels. So if you look at this picture on the right side of the screen here, this is an aortogram. So dye has been injected into the aorta and it is filling the great vessels heading to the arms and the head. You can see a tight narrowing right here of the left subclavian artery, and that's going to produce a weak pulse in the left arm, possibly weaker than what you see in the right arm. And this is the kind of lesion that you often see in Takayasu's arteritis. And the classic picture to show you in a board question is an aortogram just like this one here. In addition to a difference in pulses, you may detect a blood pressure difference between the arms and legs, or you may detect a blood pressure difference between the left and right arm. You can also hear bruits over the arteries sometimes. And then very similar to temporal arteritis, this condition is also associated with a high SED rate, and it is also treated with steroids. So back to our overview slide, we've now discussed both of the large vessel vasculitises, temporal arteritis and Takayasu's. And the key features of temporal arteritis to know are that it occurs in elderly females and that they can have a headache, and then also remember that blindness is the feared complication. Takayasu's, on the other hand, is a young Asian female. It's pulseless disease, and both of these conditions have granulomatous inflammation and high SED rates. Now we're going to move on and talk about the medium vessel vasculitides, and we'll start with Kawasaki's disease. Okay, so Kawasaki's disease is a disorder in which there's autoimmune attack of medium-sized blood vessels. Most cases occur in children, and much like Takayasu's arteritis, this is more common in Asia compared to other parts of the globe. Classic areas of the body that are involved in Kawasaki's disease include the skin, lips, and tongue. Many children with this disorder develop a diffuse red rash. It can involve the palms and soles, and it can also desquamate, meaning the skin can fall from the underlying layers of the body. Children with Kawasaki's classically have changes in the lips and oral mucosa where those structures become red. This is called a strawberry tongue, and I'll show you a picture of this in a minute. And the feared complication in a child with Kawasaki's disease is that coronary aneurysms can develop, and these can rupture, and that can lead to ischemia and myocardial infarction and potentially even death in a child who has Kawasaki's. There are two agents used for treatment. One is IV immunoglobulin. This is a collection of immunoglobulins from pooled donors, and it suppresses inflammation in the medium-sized blood vessels. And then the other treatment is aspirin. Now normally we don't give aspirin to children because there's a risk of a rare liver condition called Reye syndrome. But the one situation where we do use aspirin is in Kawasaki's, and that's because it's very effective, especially at limiting the development of coronary aneurysms. So even though there's a small risk of liver damage from aspirin, we give it to children with Kawasaki's because it's effective. On the left side of the screen is a picture of a child with a bright red tongue to remind you that strawberry tongue is a finding in Kawasaki's disease. And on the right side of the screen is a coronary angiogram. Now children should have very, very healthy coronary arteries, but this coronary artery has a big bulge right here. That is an aneurysm, and that is what can occur in Kawasaki's disease, and it can lead to death of the child, and that's why this is such a serious condition. Here's a picture showing the progression of the disease over time. The first 2 weeks is called the acute phase, and this is when children will have fever and arthritis. They sometimes have myocarditis, which can include chest pain, and this is when the rash develops on the skin, especially on the palms and soles. After about 3 or 4 weeks, the skin will desquamate on the palms and soles. And after about 3 or 4 weeks is when the aneurysms develop, and this is why you try to recognize this and treat it during the acute phase to prevent the formation of aneurysms. The symptoms of Kawasaki's disease are very similar to the symptoms of scarlet fever, which is a complication of strep pyogenes throat infection. And in fact, telling scarlet fever from Kawasaki's can be very difficult in clinical practice. Both Kawasaki's and scarlet fever can occur in children. They both involve fever and a diffuse red rash. Scarlet fever, however, will usually involve a sore throat preceding the illness, and this is very important to remember so that you recognize it in a board question. Other features of scarlet fever, just by way of review here, are many small papules on the skin. It's called sandpaper skin. This is a drawing of a child with scarlet fever here. There is a strawberry tongue in scarlet fever, just like in Kawasaki's disease, and the skin does desquamate in scarlet fever, similar to Kawasaki's disease. What you want to look for is that sore throat preceding the illness to know that it's scarlet fever and not Kawasaki's. Let's review Reye syndrome, which is something that can occur if children are administered aspirin. Reye syndrome involves encephalopathy and liver failure and fatty infiltration of the liver. The symptoms a child will present with are vomiting and confusion and seizures and coma. This often follows a viral illness, especially influenza or varicella. The underlying pathophysiology is diffuse mitochondrial insult. And importantly, this syndrome is associated with aspirin use in children. Careful epidemiology case-controlled studies many decades ago found that children who took aspirin for one of these viral conditions were far more likely to get Reye's syndrome. As a result, aspirin was discontinued as a routine treatment for children, and Reye's syndrome is very rare now because of that. The one exception where aspirin is still administered to children is Kawasaki disease, and that's because Kawasaki is very dangerous because children can develop coronary aneurysms and die, and aspirin is highly effective for the condition. Our next medium vessel vasculitis is called Berger's disease. It's also called thromboangiitis obliterans, and this condition classically occurs in male smokers. In fact, it almost never occurs in non-smokers. This condition involves poor blood flow to the hands and feet that leads to gangrene. This is a picture of gangrene of the foot to remind you of what can happen in Berger's disease. Often these patients have auto-amputation of their digits, meaning their fingers or toes fall off. They also can develop something called superficial nodular phlebitis, which is where they develop tender nodules over the course of a vein. In addition, they can develop Raynaud's phenomena, where they have poor blood flow to their hands and can develop ulcers. They can also get something called segmental thrombosing vasculitis, where they have blood clots that cut off the blood flow to the hands and feet. The treatment for this condition is smoking cessation. As I said, it almost always occurs in a smoker, and if they stop smoking, the symptoms will improve. Our last medium vessel vasculitis syndrome is called polyarteritis nodosa, and the most important thing to remember about this is that it is immune complex mediated. This is unique among the vasculitis disorders in this module. This is the only one mediated by immune complexes. So complexes of an antibody, like I'm drawing here, attached to some antigen will circulate through the plasma, and they will deposit in the skin and tissues. This is an example of a type 3 hypersensitivity reaction. The classic demographic to develop polyarteritis nodosa is someone who is Hep B positive. There are idiopathic cases, but in a board question it is almost always going to be someone who is Hep B positive and then develops a bizarre constellation of symptoms. And because the pathophysiology involves these circulating immune complexes, they can deposit in many, many different places, causing a wide array of symptoms. So they can deposit in nerves and give motor and sensory deficits. They can deposit in the skin and cause nodules or palpable purpura, like I've shown right here. And they can deposit in the kidneys and cause renal failure. Just like in Kawasaki's disease, polyarteritis nodosa can lead to aneurysms and constrictions of arteries that you can see when you do an arteriogram. What's different is that in polyarteritis nodosa, you usually see the aneurysms in the kidney and the liver and the mesenteric arteries and not in the coronary arteries. There's a classic sign on an arteriogram called a rosary sign. So you may know that a rosary is a series of beads on a string like what I'm drawing here. So what you see when you do an arteriogram is you see a series of bulges like this represented by the aneurysms, and that's called a rosary sign. And if you see that when you inject dye into the arteries supplying the liver or the mesenteric arteries, that is suggestive of polyarteritis nodosa. If you biopsy an artery of an affected medium vessel, you will see fibrinoid necrosis and inflammation in the vessel wall. So the classic case to know for your boards is a patient with a history of hepatitis B who now presents with a bizarre constellation of symptoms that may include nerve deficits, skin nodules and purpura, and finally renal failure. Because polyarteritis involves the medium-sized vessels, it usually doesn't produce red blood cell cast and glomerulonephritis. Instead, what you see is renal ischemia and decreased blood flow to the kidneys, and you see rising BUN and creatinine and renal failure. You can make the diagnosis by doing an angiogram and looking for aneurysms, usually in the mesenteric vessels or vessels that supply the kidneys or the liver. This is a picture of a coronary angiogram with an aneurysm right here. What you would see in polyarteritis is a similar angiogram of other blood vessels showing aneurysms. You can also do a tissue biopsy of one of the affected blood vessels. And the treatment for polyarteritis nodosa is corticosteroids and cyclophosphamide, similar to the treatment for the ANCA-mediated small vessel vasculitis diseases, which we'll talk about in a few slides. So back to our overview slide, we've now gone through all three of the medium vessel vasculitis syndromes. The buzzwords to remember for Kawasaki's disease are that it occurs in an Asian child who has a red rash and a strawberry tongue. Berger's disease is that smoker's disease where they get gangrene of their hands and sometimes their feet. And then polyarteritis nodosa, remember that this occurs in Hep B, and remember that it's immune complex mediated. Now we're going to move on and talk about the four small vessel vasculitis syndromes, but really these can be split up into two groups. Hinoch-Schönlein purpura is really a disorder all of its own that involves IgA, and then Scherg, Strauss, and Wegener's and microscopic polyangiitis are all ANCA diseases, so we're going to talk about those as one group. So let's start by talking about Hinoch-Schönlein purpura. Hinox-Schönlein purpura is the most common childhood systemic vasculitis, and you should remember for board questions that this is always going to be a child who develops this condition. It often follows an upper respiratory infection, and it's associated with IgA antibody deposition. And in the renal modules, I talk about IgA nephropathy, and that is a very similar condition to Hinox-Schönlein purpura that only involves the kidneys, but it also often follows a URI and is associated with IgA antibodies. The vasculitis in Hinox-Schönlein purpura comes from IgA complex deposition, and this is how you can get IgA nephropathy in the kidneys. There is also C3 complement deposition as well, and this is interesting because, as you may know, IgA antibodies do not fix complement via the classical pathway, but complement is often involved in Hinox-Schönlein purpura and IgA nephropathy, and the complement is believed to be activated via the alternative and the lectin pathways. The way you're going to recognize Hinox-Schönlein purpura in a board question is that it's going to be a child who had a recent upper respiratory infection and now has a constellation of findings in the skin, the GI tract, and the kidneys. So the IgA deposition can involve the skin, and it classically causes palpable purpura on the buttocks or legs. This is a picture of a child with palpable purpura on his legs to remind you of this finding. In the GI tract, the IgA deposition can lead to abdominal pain and melena, so this will be a child who had a recent upper respiratory infection and now has blood in the stools. And then finally in the kidneys, you will see evidence of nephritis, so you can see blood and protein in the urine. So just to review, the classic case is a child with a recent URI who now has palpable purpura and melena. The tissue biopsy is the best test, and it will show evidence of IgA deposition. This is a tissue biopsy stained for IgA here, and you can see that portions of it are lighting up where there is IgA deposition around blood vessels. Usually, Hinox-Schönlein purpura is self-limited and requires no treatment. The feared result is renal failure from the IgA deposition in the kidneys. This is more common when adults get the condition. Some severe cases have been treated with steroids and cyclophosphamide, just like many of the vasculitis syndromes, but this is rarely done because, as I said before, it's usually a self-limited problem. So back to our overview slide, the buzzwords for Hinox-Schönlein purpura are a child with a recent URI who has melena. Now we're going to move on and talk about the last three small vessel vasculitis syndromes, and they are all very similar. These are ANCA-mediated diseases. There are three small vessel vasculitis disorders that are called ANCA diseases, and they get this name because they all involve anti-neutrophil cytoplasmic antibodies, and I'll explain exactly what these antibodies are in a minute. But the three ANCA disorders that all cause vasculitis are Sjögren-Strauss syndrome, Wegener's granulomatosis, and microscopic polyangiitis. All three of these disorders have some element of pulmonary involvement, and they all cause the same renal problem, and that is crescentic rapidly progressive glomerulonephritis, or crescentic RPGN, which I discuss in more detail in the renal section in the video on glomerulonephritis. But by way of review, in crescentic RPGN, crescents form in the glomeruli. This is an example of one here, and that's what you see on a biopsy of the kidneys. In addition, if you do immunofluorescence staining in crescentic GN in the ANCA diseases, what you will see is pauci immune findings. This means there is a paucity of immunoglobulins, or in other words, a lack of immunoglobulins, so that the immunofluorescence staining is negative. So if you stain for antibodies and they are present in the glomeruli will light up. But in the ANCA diseases, the glomeruli look black, like this one on the screen right here. And the reason it looks black is because it's not lighting up for the presence of any immunoglobulins. In addition, all three of these disorders cause the nephritic syndrome, so patients can present with proteinuria and hematuria and all the elements of the nephritic syndrome. So let's talk in more detail about anti-neutrophil cytoplasmic antibodies, or ANCAs. These are autoantibodies that attack proteins inside of neutrophils. There's a picture of a neutrophil on the screen here. And there are two patterns of antibody deposition that distinguish the different ANCA diseases. The first pattern is called the cytoplasmic pattern, or c-ANCA. These are antibodies that are usually directed against proteinase 3 inside of the neutrophil. If you stain neutrophils with immunofluorescent staining looking for these antibodies, you will see the neutrophil light up in the cytoplasm, like where I'm indicating with my pen right here. Hence the name c-ANCA for cytoplasmic antibodies. This pattern of antibody staining is only seen in Wegener's. We'll talk more about that in a minute. The second pattern of antibody staining is called p-ANCA, and P stands for perinuclear. These are usually antibodies directed against myeloperoxidase inside of neutrophils. In this pattern, the portions of the neutrophil that will light up on immunofluorescent staining are the perinuclear portion, so you will see immunofluorescent brightness around the nuclear portion of the neutrophil, and that's the p-ANCA or perinuclear pattern. And this pattern is seen in the other two ANCA diseases, Sjögren-Strauss and microscopic polyangiitis. So now let's talk about the specific disorders, and we'll begin with Sjögren-Strauss syndrome. And Sjögren-Strauss syndrome is the easiest ANCA syndrome to recognize because it looks like a bizarre case of asthma. Most people who have asthma get their symptoms initially as a child and it may persist into adulthood, but people with Churg-Strauss often develop asthma for the first time as an adult, and the asthma is often refractory to medical therapy. In addition, they have many bizarre extrapulmonary findings associated with their asthma. They may have inflammation of the sinuses and sinusitis, and they frequently develop neuropathy as well. So when you see a very strange case of asthma, you should think of Churg-Strauss. Key lab findings are a high level of eosinophils in the peripheral blood. I've shown an eosinophil on the screen here to remind you of that. This is a p-ANCA positive disorder, and there are also elevated levels of IgE. In addition to the clinical findings I've listed above, you can often see palpable purpura in this condition, so palpable purpura in someone with asthma should make you think of Churg-Strauss right away. This is a granulomatous inflammatory disease with necrotizing vasculitis seen on biopsies. In addition to the symptoms I've already described, you can get symptoms from cardiac involvement, GI involvement, and of course in the kidneys you can get nephritis. And this is treated with steroids and cyclophosphamide, which are the two treatment options for all three of the ANCA vasculitis diseases. The next ANCA disease is Wegener's granulomatosis, which is also called granulomatosis with polyangiitis. And the classic triad of symptoms here is sinusitis, otitis media, and hemoptysis, and that's because patients with this condition get inflammation of the upper and lower airways. So upper airway inflammation gives you sinusitis and otitis media, and I've shown a picture of the sinuses here to remind you of that, and lower airway inflammation gives you symptoms of hemoptysis. In addition, there is characteristic renal involvement with hematuria and red cell CAS, and these patients can also have palpable purpura. This is a granulomatous disease, and that's easy to remember because granuloma is in the name of the condition. The antibodies that are elevated here are c-ANCA. Remember, this is the only c-ANCA disease. The other two ANCA diseases are p-ANCA, and this is also treated with steroids and cyclophosphamide. The final ANCA-mediated disease is microscopic polyangiitis. Just like Wegener's, this involves hemoptysis and kidney failure and palpable purpura. The way you can tell it apart from Wegener's is by looking for a couple of key features. There's no upper airway involvement in microscopic polyangiitis, so you won't see sinusitis and otitis media. In addition, this is a p-ANCA disease, not a c-ANCA disease in most cases. And then finally, there are usually no granulomas on biopsy in microscopic polyangiitis. This is not a granulomatous inflammatory condition. The treatment for this vasculitis is steroids and cyclophosphamide, just like for the other ANCA diseases. Let me briefly mention Goodpasture's syndrome, which is often confused with Wegener's and Churg-Strauss and microscopic polyangiitis. Goodpasture's is caused by an antibody to collagen. It is an example of a type 2 hypersensitivity reaction. There are antibodies developed against the alpha-3 chain of type 4 collagen, and you can find type 4 collagen in the glomerular basement membrane, so you get attack in the kidneys. You can also find type 4 collagen in the lungs and the alveoli, so you get lung involvement. So these patients present with hemoptysis and nephritic syndrome, and this can make you think of Wegener's or microscopic polyangiitis, but there are a couple of key differences. The immunofluorescent staining in Goodpasture's is positive. I've shown an example of it in the bottom right of the screen here. There is a linear immunofluorescent pattern when you stain for IgG or C3, and remember that in all the ANCA diseases you will see a negative immunofluorescent staining pattern. It's called a pauci-immune pattern. So the classic case of Goodpasture's is a young adult, usually a male, who has hemoptysis and hematuria, but then you're going to know it's Goodpasture's by the immunofluorescent staining pattern and the absence of ANCA antibodies. So back to our overview slide, we can now complete this slide by filling in the right-hand column. So for Churg-Strauss, the thing you want to remember is asthma. This is going to look like asthma with extrapulmonary involvement. There will be high levels of eosinophils, and this is a p-ANCA disease. In Wegener's, you want to look for evidence of sinus involvement as well as the kidneys and the lungs, and then remember this is a c-ANCA disease. And then finally, microscopic polyangiitis, recall, looks a lot like Wegener's. It will involve the kidneys and the lungs, but it will be a p-ANCA positive disorder. Here's a summary slide of all the different treatments. Both of the large vessel vasculitis syndromes are treated with steroids, and all of the small vessel vasculitis syndromes can be treated with steroids and cyclophosphamides. The ones that are hard to remember are the medium vessel vasculitides. Polyarteritis nodosa is treated with steroids and cyclophosphamides. It's very similar to the small vessel vasculitis syndromes. Kawasaki's disease has that unusual treatment of IVIG and aspirin in children, and Berger's disease is treated with smoking cessation. And lastly, here's a summary of the key blood tests. The most important blood test for the large vessel vasculitises is the elevated SED rate. In the small vessel vasculitis syndromes, you will see p-ANCA and IgE levels elevated in Churg-Strauss. You will see c-ANCA in Wegener's. Remember, that's the only c-ANCA disease. And microscopic polyangiitis will have p-ANCA positivity. And that concludes our module on vasculitis.